This conference will now be recorded.
So today our next topic is multiple pregnancy. Regarding epidemiology, the incidence of the multiple pregnancies, particularly the dizygotic, it has increased since the 1980s. Or generally speaking, the incidence of the twin pregnancy is 1 in 80. And multiple births, they account for 3% of all live births, 6.3% of stillbirths, 12.7% of the neonatal deaths. They are more common in black ethnic group, and the rising multiple birth rate is mainly due to increased use of the assisted reproductive techniques. And women with the multiple pregnancies, they need more monitoring during their pregnancy than women with singleton pregnancies. You should have a clear concept about on zygosity, chorionicity, amnionicity. Zygosity, it refers to whether the pregnancy is resulting from one fertilized egg, then we will call it monozygous. If it is resulting from two fertilized eggs, then we will call them dizygous pregnancy. Chorionicity, chorion, is the outer membrane of the placenta. And here we need to note that there is a single chorion or double chorion. Then amnionicity, this is the number of the inner amnions. We also call it amniotic membranes that surrounds the baby. So this is the inner layer, it would be amnion, and the outer layer would be chorion. Then monozygotic twins, they account for 3.5 out of 1,000 twin pregnancies, so it falls to 30%. So the monozygotic twin pregnancies, they result from splitting of a single fertilized oocyte producing monozygotic identical twins. While the majority they are identical, there are monozygotic offsprings who are genetically and phenotypically dissimilar. So the incidence I will explain to you with the help of a picture. And the incidence of the dizygotic twins is 1.3 to 49 in 1,000. So they account for like almost 70% of the twin pregnancies. So it results from the fertilization of more than one oocyte producing dizygotic non-identical twins, and not they don't occur at the constant rate, and they depend on the geographical and the genetic variations. Assisted reproductive techniques use increasing advancing maternal age, that is the maternal age between 35 to 39, multiparity, and the BMI. And they will always, dizygotics, they will always have two placenta. And dichorionicity, it occurs in 80% of the twins, and dichorionic twins, they can be monozygous, and genotyping is required to confirm zygosity. Monochorionicity, it confers major increase in perinatal morbidity and mortality when compared to the dichorionicity. So sometimes they want to ask you, sometimes they will give you the duration, sometimes they will give you the structure. They will like in the options. Okay, so they will ask you when are the dichorionic diamniotic twins are formed. Your answer is when the zygote splits between 1 to 3 days or at morula stage. Monochorionic diamniotic twinning, it will occur if the cleavage occurs between day 4 to 8 or at the blastocyst stage. Monochorionic monoamniotic twins would be formed if the blastocyst has implanted into the endometrium and cleavage is occurring between day 8 to 13. And if the embryo divides between day 13 to 15, then conjoined twins they would form. So conjoined twins they will form by division of the embryonic disc. So quickly, comparison of the monozygotic versus dizygotic twins. So more identical twins, they are also or monozygotic twins, they make up 1/3 of all twin pregnancies, and dizygotics, they make up 2/3 of all pregnancies. And the identical twins, they arise from division of the fertilized oocyte into the two embryonic layers. And the dizygotics, they occur by fertilization of two oocytes with two mature spermatozoa. So these are actually two separate pregnancies. So the identical twins, they will be genetically identical, and the dizygotic twins, they will be genetically different. And chorionic cavity and the amniotic sac, they will have differences according to the division or timing of the division, as we discussed before. And dizygotic twins, they are always going to be dichorionic, diamniotic at the time of starting this pregnancy. So different types of monozygotic pregnancies. Dichorionic diamniotic, the twins, they have separate chorionic sac and separate placentae and separate amniotic sacs. And like I said, they will occur within the first division will occur within first 3 days, and they account for 1/3 of the monozygotic twins. Monochorionic diamniotic, the twins, they share a single chorionic sac, and the twins share a placenta, but they have a separate individual amniotic sac. Division will occur between day 4 to 7 after conception, and it accounts for like 70% of the monozygotic twin pregnancies. Monochorionic, monoamniotic, these twins, they share a single chorionic sac, and the twins, they share a placenta and a single amniotic sac. And the division occurs between day 8 to 11 after conception, and they account for 1 to 5% of the monozygotic twins. Monochorionic, monoamniotic, or the conjoined twins, the twins, they share the placenta and amniotic sac, and they are conjoined. So it means that the division has taken place after 12 days after conception onwards, and they account for less than 0.1% of the pregnancies. Here the same picture, just want to highlight the point that because that sometimes they will give you the only the stage, and sometimes they will give you the division. So like I mentioned before, that the dichorion, that if the division is occurring early, we are getting the dichorionic and diamniotic. You can see the pink line, and you can see the turquoise line, blue line inside this one. So each baby has its own chorion and amnion. So that is dichorionic, diamniotic. Here they have a common chorion, and while you can see a blue layer inside here between the two babies dividing them, so this is a monochorionic diamniotic pregnancy. This is a monochorionic and monoamniotic pregnancy because there is no membrane between the two babies. And here the babies, they are fused with each other, okay? And the division has taken place at the time of embryonic disc formation. So how do we know that, um, how do we suspect that the woman is carrying the twins? On physical examination, fundal height and abdominal girth, they are unusually large for the gestational age, and 2 or more fetal heart rates, they can be heard on auscultation. On ultrasound, obviously we are going to see two different babies, and if we will pay attention, then in the first trimester we can determine their chorionicity as well. We'll go talk about that in detail. Let's go over the general complications of the twin pregnancy. So we can divide the complications into maternal illness, maternal illnesses, and the fetal illnesses. Mother is at risk of preterm labor and birth, hyperemesis gravidarum because of plenty of the beta HCG, and gestational diabetes, preeclampsia, cervical incompetence, premature rupture of membranes, placental insufficiency, uterine atony, then birth complications like prolonged first stage of labor, premature placental abruption after birth of the first fetus, endocardial prolapse, and increased risk of maternal morbidity. Then among the fetal illness, twin-to-twin transfusion syndrome can occur, which affects 10 to 15% of the monochorionic twin pregnancies and twins that share the placenta. So the blood is continuously shunted from one twin to the other one through the vascular anastomosis and on the shared placenta, and it will pose risks to both fetuses. Recipient twin here will become polycythemic, hypovolemic, and there can be polyhydramnios in the diamniotic pregnancies. The donor twin can have anemia, growth retardation, hypovolemia, dehydration, like the stuck twin or the cocooned appearance can be seen, oligohydramnia in diamniotic pregnancies. Cord entanglement, it can occur only in monoamniotic twin pregnancies because there is no membrane to separate the two babies and their cords and placenta. They are at increased risk of neonatal morbidity and mortality. Miscarriage and the vanishing twin, it affects like 21% of the twin pregnancies. Sometimes they are asking you that in twin pregnancy, the incidence of congenital malformations is twice that of the singleton pregnancies or like what, okay? So just remember that the chance of having uh, congenital fetal malformations would be 4.9% in multiple pregnancies as compared to higher as compared to the singleton pregnancies. Then the chance of having malformations in dizygotic twins is more than that of the singleton pregnancies, so the increased risk is 2 to 3%. Then the frequency in monozygotic twins is 2 to 3 times higher the risk in the dizygotic twins. So the common abnormalities would be neural tube defects or congenital heart disease. In monozygotic twins, limb reduction defects and the bowel atresias, they may also be seen. So what is the incidence of IUGR in the unexplained stillbirths in the twins? They are that is 66%, and it is associated with birth weight less than 10th centile versus 39% for the singleton births. IUFD or the single fetal demise, the overall stillbirth rate in multiple pregnancies is higher than in singleton pregnancies. Perinatal mortality is 3 times higher in monochorionic compared to the dichorionic pregnancies. Prenatal mortality is 3 times higher in twin pregnancies compared to singleton pregnancies. Complications specific to both monochorionic and the dichorionic twins, these are discordant anomaly, vanishing twin, and the fetus papyraceous. Complications more with the monochorionic twins are selective fetal growth restriction and the single fetal demise. And similarly, the complications which are unique to monochorionic twins, these include twin-to-twin transfusion syndrome and um, twins anemia, polycythemia sequence, and then twins reversed arterial perfusion syndrome. So all of these things, these are reverse arterial perfusion syndrome. That is, all of these things are unique to monochorionic twins. How do we provide antenatal care for the twins? So there should be a core team, and then there should be an advanced team that will, if we need extra help for the moment. So the core team, it should include a specialist obstetrician, specialist midwife, and ultrasonographers. It should offer information as well as emotional support at the first contact with the advice covering antenatal, postnatal mental health and well-being, antenatal nutrition, the risks, symptoms, and signs of preterm labor, the potential need for corticosteroids, and likely timing and possible modes of delivery, and breastfeeding and advice on parenting. And then, if the woman is showing signs of stress, then we can elevate the level and send her to the perinatal mental health professionals, physiotherapists, especially they are very likely to develop pelvic girdle pain, so we need to refer them. Then infant feeding specialist and dietitians. Referral to the enhanced team, it should not be made routinely. It should be given in selective cases where the woman is likely to benefit from these services. So the coordinate clinical care, it leads to less visits to the hospital, and our aim should be to provide care as close to the woman's home as possible so that she doesn't have to travel, and provide continuity of care within and between the hospitals and the community. So this is shared care plan. Regarding antenatal appointments, we should offer women with uncomplicated monochorionic diamniotic twins at least 9 antenatal appointments with a healthcare provider from the core team. At least 2 of these appointments, they should be with the specialist obstetrician, and we should combine appointments with ultrasound when the CRL is between 45 to 84 millimeters, then at 16, 18, 20, 22, 24, 28, 32, and 34 weeks. We should offer elective births from 36 weeks for the monochorionic twin pregnancies after a course of antenatal corticosteroids. So if the women have uncomplicated monochorionic monoamniotic twin pregnancies, then they should also get 9 antenatal appointments, and 2 of these should be with the specialist, and the combined appointments with ultrasound. Once the CRL is between 45 to 84, then we should provide them appointments at 16, 18, 20, 22, 24, 26, 28, and 30 weeks. So a total of 9 appointments should be organized. So then recently done to all monochorionic twins. Every 2 weeks we should see them until delivery. Offer elective cesarean section can be offered in monochorionic twin pregnancies from 32nd week onward, because these are at highest risk of fetal demise because of the cord entanglement. So, and this should be at this early age, we need to give them corticosteroids and then deliver them. And the women who have uncomplicated dichorionic twin pregnancies, they should get at least 8 antenatal appointments, and 2 should be with the specialist, and then we should offer them these serial assessments from 11 to 13 weeks onwards, when the CRL is between 45 to 84 millimeters. Then we should see them at 20 weeks, 24 weeks, 28, 32, and 36 weeks. Okay. So then additional appointments without scans should be offered at 16 and 34 weeks. And for the dichorionic diamniotic twin pregnancies, they should be delivered from 37 weeks onwards. And the women who have uncomplicated monochorionic, triamniotic, and dichorionic triamniotic triplet, at least 11 antenatal appointments with a healthcare professional from the core team. Now, since the risk would increase, so the monochorionic triamniotic and dichorionic triamniotic, they should get at least 11 antenatal appointments. 2 should be with the specialist, and when we should offer these serial assessments once the CRL is between 45 to 84. So at 11 to 13 weeks, then at 16, 18, 20, 22, 24, 26, 28, 30, 32, and 34 weeks. So actually from 16 week onwards, we are going to see them fortnightly. So offer elective births from 35 weeks after a course of corticosteroids. Offer women with uncomplicated trichorionic triamniotic triplets at least 7 antenatal appointments. 2 should be with the specialist, and then again surveillance should start between 11 to 13 weeks, and then at 20, 24, 28, 32, and 34 weeks. Additional appointments without scans can be offered at week 16 of gestation. Elective births should be offered from 35th week of the gestation onward, and that after a course of corticosteroid. This is how we are caring for the trichorionic triamniotic pregnancies. So women with twin triplets involving a shared amnion, they should be offered individualized care from a consultant at the tertiary care level, like at the level of the fetal-maternal unit. It is very important to determine gestational age and the chorionicity. So offer women a first ultrasound when the CRL reaches 45 to 84 millimeters, that would be between 11 to 13 plus 6 weeks, to determine gestational age, chorionicity, and screen for the Down syndrome. So this chorionicity, it should be determined from week 10 onwards. However, the aim of the 11 week here is to keep the minimum ultrasound appointments that the woman need to attend within the short period, short time, especially if she is already known to have a twin triplet pregnancy. First ultrasound may identify fetal anomalies such as cystic hygroma and anencephaly. As you know that these are anencephaly is the first anomaly of the CNS that can be diagnosed at around 10 weeks. Ideally, screening for the Down syndrome, it should be done at the same time. So another SBA question, that one baby is small, one is large. So whose diameter, whose CRL should be taken for estimating the fetal age? So use the largest baby to estimate gestational age to avoid the risk of estimating it from a baby with early growth pathology. So measure the healthy one and then for the baseline record, and then compare with the size of the healthier or the larger twins for the remainder of the pregnancy. So recording twins' relative positions to each other is a reliable method of labeling offered to them, and they can be designated as twin A or twin B. It is twin 1 and twin 2, and then you should determine the chorionicity. So how do we determine the chorionicity? Using the number of the placental masses, the lambda or the T sign, and the membrane thickness. Lambda sign, it is formed by a tongue of placental tissue within the base of the dichorionic membranes. Monochorionic twins, they have a single placental mass and thin intertwined membranes that inserts into the placenta at a perpendicular plane, that is the T sign. Dichorionic twins, they have two placental masses or adjacent placental masses forming a lambda sign. Membrane thickness of less than 2 mm is suggestive of monochorionic twins. For women presenting after 14 weeks, use all of the above features and discordant fetal sex for the determination of the gender, and we can say that for determination of the chorionicity. A photographic record, it should be taken and placed in the patient's notes and documenting the appearance of the membranes attachment to the placenta. Although ultrasound assessment of the chorionicity is very accurate, but it doesn't have 100% sensitivity. So using criteria mentioned, like we mentioned, for the sensitivity and the specificity, they are 95%. So don't use 3D ultrasound to determine chorionicity. There can be some problems in determining the chorionicity, like if poor transabdominal views due to retroverted uterus or high BMI. In that case, with consent of the patient, we can use TVS, transvaginal scan, to determine chorionicity. If it is not possible to determine chorionicity, a photographic record of the ultrasound appearance of the membranes attachment to the placenta, it should be retained and seek a second opinion. If it is still difficult to determine chorionicity, refer to a healthcare professional competent in determining chorionicity as soon as possible, as chorionicity is best determined before 14 weeks of gestation. If it is still difficult after referral, like due to late booking, then manage as monochorionic pregnancy until proven otherwise. So networks, they should agree care pathways to ensure that each woman has a care plan in place that is appropriate for the chorionicity. There are certain indications for referral to the fetal-maternal unit, like monochorionic, monoamniotic twins, and triplets, monochorionic, diamniotic, dichorionic, diamniotic triplets. So all types of triplets, they should be going to the fetal-maternal unit. Then pregnancy is complicated by discordant fetal growth and discordant fetal death, congenital fetal malformations, or twin-to-twin transfusion syndromes. So you need to send them to the advanced level. Now, how do we identify that this is a lambda sign or this is a T sign? Sometimes they are just giving you a picture and asking you to identify the type of the twin pregnancy. So if you see this lambda sign, what is this lambda sign? That the two pregnancies are dichorionic. So if they are dichorionic, then obviously they are diamniotic also. So this is the placental tissue which is invaginating between the two chorions. So it is forming a thick tongue. So we call it a lambda sign. You can see it here. Okay. And like in the real life, if you will see, it is very obvious if you have like some experience. Let me show you this one. This is the placental tissue invaginating between the membranes of the two babies like that. Okay, this is what we call lambda sign. Now let's go and see that what is the twin sign. This is the T sign. The thin membranes are attached at the placenta and the endometrial lining interface, and between the two fetuses, you can see here. This is our T sign like that. Okay, and the membranes are also very thin. Okay, so after that, once you have determined the chorionicity, zygosity, then we should be screening them for the syndromes, and it should be like the routine procedure. And we already assume that the chance of having the problems is higher in the twin pregnancies. So first of all, we should give the mother or couple the information counseling before and after the screening test, and we should tell them that the likelihood of having this Down syndrome is higher in the multiple pregnancies, and they have different options for screening and the aims and the possible outcomes of all screening tests. And then after carrying out these, if the screening tests they turn out to be positive, then we will have to do the diagnostic test. And we should tell them that there is a higher chance of false positive rate screening test in the multiple pregnancies. And then they should also be counseled about the chance that they will have to go for diagnostic tests, and that there are greater risk and complications from the invasive tests. Like if we offer invasive testing, of course we will do this amniocentesis or we will do chorionic villus sampling. So both have their own complications. So and then it can put some physical and psychological stress on them, and especially if they have to choose about the fetal reduction, they can blame themselves that they have opted to kill the sick baby. And the risk of Down syndrome in the general population is 1 in 700 pregnancies. And monochorionic twins, they are not at an increased risk of chromosomal anomalies over dichorionic twins. And the prevalence of aneuploidy is slightly increased overall in multiple pregnancies due to that indirect association with advanced maternal age. And the risk of monozygotic twins is the same as for the singletons, but for the dizygotic twins, the risk is doubled as each twin has its own risks. And for twin pregnancy, we should map the fetal positions. Basically, we are looking at the back of the babies, that where is the back of the baby, and use the combined test. Combined test is it is more sensitive and specific. That's why we offer it in the first trimester. So it includes knuckle translucency, beta HCG, BAP-A, and when the CRL measures 45 to 84 millimeter, that would be between 11 to 13 plus 6 weeks with the first ultrasound. And if the first ultrasound screening it cannot be offered to the woman like she is booking late, then we have to think about the second trimester quadruple test. Quadruple test, as you know, it includes alpha fetoprotein, beta HCG, serum estriol, and inhibin, and it should be offered between 15 to 20 weeks. And we should explain to the woman that potential problems of such screening, what we can face. Okay. Then, if positive screening test, definitive diagnosis can be made by invasive testing like CVS or amniocentesis. Both procedures, they are valid options, but a double amniocentesis, it has a lower risk of mistakenly sampling the same fetus twice. Explain the likelihood that she's at 1 to 2 to 3% higher risk of losing the fetus as compared to the singleton pregnancies. And then the chance of having a miscarriage and other procedure related complications is 1 by 50, like 2% in the twin pregnancies. And for the triplet pregnancies, we should map the fetal positions, use knuckle translucency and the maternal age when the CRL measures 45 to 84 millimeters of mercury, that is between 11 to 13 plus 6 weeks with the first ultrasound. And if the first screening cannot be offered, the woman books late, then don't use the second serum screening. There is no place for it. Okay, no second serum screening in the triplets. Calculate the risk of the Down syndrome per pregnancy in monochorionic pregnancies for both babies in dichorionic and trichorionic pregnancies. And then refer to the fetal-maternal unit if the woman whose risk of Down syndrome exceeds 1 in 150. So regarding fetal anomaly and the growth scans, for the structural abnormalities, we should offer anomaly scan at 18 to 20 weeks, as in the routine care, and consider scheduling scans for twins and triplets at slightly later gestational age than in the singleton, and be aware that the scans they will take longer. Allow 45 minutes for the anomaly scan in twins and the triplet pregnancies, and the detection rate of the this congenital fetal malformation on ultrasound for the twins, they are similar to the singletons. So how do we monitor for IUGR in a twin pregnancy? As we mentioned before, that IUGR occurs in 30% of the monochorionic twins and 20% of the dichorionic twins. 66% of unexplained stillbirths in twins, they are associated with a birth weight less than 10th centile versus 39% for the singleton births. Fetal growth ultrasound is done 4 weekly for dichorionic twins and 2 weekly for the monochorionic twins. Monochorionic twins, the scan starts at 16 weeks and then every 2 weeks till to 24th weeks. Then the growth scans at 28 weeks, 32 weeks, 34 weeks, and 36 weeks. For the dichorionic, we start this scanning at 20 weeks, then every 4 weeks, and offer additional appointments at 16 and 34 weeks. And estimated fetal weight discordance using more than two biometric parameters at each ultrasound scan from 20 weeks. And we should aim to undertake scans at intervals of less than 28 days, that is 4 weeks. We should consider more than 25% difference in the size between twins or triplets as a clinical indicator of IUGR, and they should be referred to the feto-maternal unit. That is, 25% difference is there in the size between the twins or the triplets, then we have to refer them to the feto-maternal unit. So in the options, they will give you that size is more than 20% difference in the selective fetal growth restriction, then you will refer them to the higher center. So read the question very carefully. Then don't use abdominal palpation or symphysiofundal height measurements to predict IUGR in twins or triplet pregnancies. And don't use umbilical artery Doppler to monitor for intrauterine growth restriction or birth weight differences. And they should be like the growth scan. For how long we should do that? We should carry it out for 30 minutes, should be done by an expert, both in cases of for the twins and the triplet pregnancies. Monitoring for the twin-to-twin transfusion syndrome and in monochorionic pregnancies, monochorionic twins, or dichorionic monochorionic triplets. We have to do it. Monitoring is done during the usual growth scan, especially for the monochorionic pregnancies, and don't monitor for twin-to-twin transfusion in the first trimester because it sets in after. If it has to set in, it will set in by 16 weeks or between 16 to 24 weeks. Okay. So like 90% of the cases of the twin-to-twin syndrome, they will occur between 16 to 24 weeks. That's why we monitor them fortnightly during this period. And only 1% of twin-to-twin transfusion syndrome, it will occur after 24 weeks. If membrane folding or amniotic fluid discordance, they are found in twins or triplets, then we have to monitor weekly to allow time for each for early intervention. Maternal care is very important. The mother should be booked at 10 weeks. We should give women with multiple pregnancies the same advice about diet, lifestyle, and nutritional supplements as in the routine antenatal care. Higher incidence of anemia, like the full blood counts, they should be done at 20 to 24 weeks and should be repeated at 28 weeks, as in the routine antenatal care. So we are doing one additional test for the twins. If the mother is carrying twins, we are doing additional test between 20 to 24 weeks. Higher incidence of hypertension, like check blood pressure and proteinuria at each appointment, as in routine antenatal care. We should give aspirin 75 milligram or 81 milligram from 12 week until birth if they have more than one of the following risk factors. Like if she is a primary gravid or age is more than 40 years, if the pregnancy interval is more than 10 years, or BMI is more than 35 at the first visit, and if there is family history of PET and multiple pregnancy. So we have to give them aspirin. Low dose aspirin should be given. Preterm birth, its chance is very high in the multiple pregnancy. Almost 58% of twin pregnancies they result in spontaneous preterm birth at less than 37 weeks. 10% of the monochorionic twins and 5% of the dichorionic twins they deliver at less than 32 weeks compared to 1% for the singleton pregnancy. What are the causes? The causes of preterm birth in twin pregnancies is the cause of preterm birth in the twin pregnancies is multifactorial and different from that of the singletons. Possible mechanisms are intrauterine infection, cervical insufficiency, and uterine stretch distension, and increased secretion of corticotropin releasing hormone from the larger placental mass and surfactant protein and protein A by the maturing fetal lung, and from the myometrial contractions. So these are the things that since the placental mass is very large, so there will be more corticotropin releasing hormone and surfactant protein A. It will come from the fetal lung, and they can cause myometrial contractions. This is because of the corticotropin releasing hormone, because the whole axis will start. So, prediction of the spontaneous preterm birth in multiple pregnancies. High risk of preterm birth if there is history of spontaneous preterm birth in a previous singleton pregnancy. So, don't use cervical length measurement with or without fetal fibronectin routinely to predict the risk of preterm birth in the multiple pregnancies. Cervical length assessment, progesterone supplementation, and cervical cerclage, they don't prevent preterm labor in twins. So the routine measurement of the cervical length is not recommended. Current evidence supports measuring cervical length from 18 weeks as a predictor of the preterm birth at less than 28 weeks, but doesn't support repeated measures. We should not use fetal fibronectin testing alone to predict the risk of the preterm birth in multiple pregnancy. A combination of cervical length measurements and the fetal fibronectin, it may be more accurate predictor of preterm birth, and don't use home routine uterine activity monitoring to predict the risk of preterm birth in multiple pregnancies. It will only increase the anxiety of the mothers. And what is the role of cervical pessary in preventing preterm birth? We, uh, we don't know yet. A lot of work is being done, so we should wait for the results of the trials. And these interventions should not be done alone or in combination to prevent preterm birth in multiple pregnancies. Like bed rest at home or in hospital, this is not advisable. Uh, Tocolytics, they are used for the completion of corticosteroids or in utero transfer, but not for the prevention of the preterm birth. Circlet is not useful, rather it may cause some harm. Why? Because the uterus is already overstretched and this is a foreign body, so maybe the chorio will start, or maybe preterm birth or miscarriage would be initiated. Giving progesterone intramuscularly or vaginally. So, and the labor is thought to occur as a result of a functional withdrawal of progesterone. Antiprogesterone like mifepristone, it is used to stimulate abortion and induce labor. However, others they have argued that progesterone level is high during pregnancy and progesterone receptors they are fully occupied, so the therapeutic benefit of adding further progesterone is unclear. So in short, there is no benefit of universal vaginal progesterone to decrease the incidence of rate of the preterm births in the multiple pregnancies. Cervical pessaries, they are not used outside research purposes. So then don't use single or the multiple untargeted courses of the corticosteroids. We should tell the woman that there is no benefit in using untargeted administration of the corticosteroids, and there are not the benefit of the targeted corticosteroid is that if she goes into preterm birth, the baby will not have respiratory distress syndrome, intraventricular hemorrhage, or necrotizing enterocolitis. Intrapartum care of the twins is equally important, especially with reference to the mode and time of the delivery. Like I said before, that we have to make a plan for the pregnancy, that for the full pregnancy, when we are going to deliver her and what will be the mode of delivery. Everything should be decided on the first antenatal visit. So discuss with the woman the timing of birth, possible modes of delivery early in the third trimester. This is when you are confirming. Okay, first time you are telling them about it in the first trimester, and then by when you enter the third trimester, tell them about the all other risks and finalize the plan of the labor and delivery. So regarding mode of delivery, vaginal delivery for cephalic, if the both twins are cephalic or they are cephalic and breech presentation, the first one is cephalic. There is a high risk of emergency C-section for the twins in labor, like 50% overall and 3 to 5% for the second twin following the vaginal birth of the first baby. Delivery should be conducted in a unit with continuous fetal monitoring and rapid access to the emergency sections. So, what are the indications for cesarean section in a twin pregnancy? Monochorionic monoamniotic due to risk of cord entanglement at 32 weeks by C-section after corticosteroids. Breech or breech cephalic presentation, like the first one is breech. Then any complication like there is PET or IUGR. Then in case of, so these are the indications for the cesarean section. Regarding the uncomplicated twin pregnancies, we should tell the woman that continuing the pregnancy beyond 38 weeks, it increases the risk of fetal death even in the uncomplicated cases. And we should offer them elective birth from 36 weeks for the monochorionic twin pregnancy after a course of corticosteroids. Offer elective birth from 32 weeks for monochorionic monoamniotic twin pregnancies after a course of corticosteroids. Offer elective birth from 37 weeks for dichorionic twin pregnancy. And delivery at these gestation ages doesn't appear to be associated with increased risk of serious adverse outcomes. In cases of uncomplicated triplet births, about 75% of the triplet pregnancies, they result in spontaneous preterm birth, that is before 35 completed weeks of pregnancy. Inform women that continuing the triplet pregnancies beyond 36 weeks increases the risk of fetal death. Offer elective birth from 35 weeks of the pregnancy after a course of corticosteroids. If elective birth is declined, offer weekly appointments with a specialist obstetrician and offer weekly ultrasound and biophysical profile, and fortnightly fetal growth scans should be offered. Intrapartum delivery should take place in maternity unit with experienced doctor, midwife, and where the facility for the operative theater, and then aesthetist is pediatrician, on-site blood bank, and the ultrasound are available. And we should do continuous electronic fetal monitoring for the both babies, and we need to label them as well, that which probe is recording the heartbeat of which baby. And then abdominal fetal scalp electrodes, they may also be applied. We can also do it like this, that for the first baby, first baby we can apply the fetal scalp electrode if the membranes have ruptured, and we can apply the CTG for the second one, but depends upon the scenario, that what is the overall condition of the mother. Epidural anesthesia, IV access, and the cross matching should be done at the time of admission. Syntocinon can be used for augmentation, and after delivery of the first twin, abdominal examination should be done, and portable ultrasound should also be done to confirm the presentation of the baby. If second twin is cephalic, we'll opt for the vaginal delivery. We should offer continuous CTG, and artificial rupture of the membrane should be done once presenting part is engaged. Establish contractions if needed with oxytocin, And active management of the third stage of the labor should be offered because the patient is already at risk of the postpartum hemorrhage. If second breech or the transverse, then we can do. If the baby is breech, we can do external cephalic version. And if the baby is transverse, then we can do internal podalic version. So it should be done through the intact membranes and can be done under ultrasound guidance. So now management of the complications. Okay, if the babies have discordant anomaly, so can we offer selective this feticide? So need to refer to FMU. Structure anomalies in the monochorionic twins, they are twice that expected in the dichorionic twins. The diagnosis of discordant anomaly in twins creates significant dilemma for the parent and the careful counseling is required. Depending upon the anomaly detected, parents they will have two choices. First, continuing the pregnancy and delivering both a normal and an affected baby. Terminating the affected fetus and risking the viability of the healthy co-twin. Prior to invasive testing, selective reduction it should be discussed and made available after appropriate counseling. Karyotyping of the monochorionic twins it should be managed in a feto-maternal unit. During amniocentesis in monochorionic twins, both amniotic sacs they should be sampled. Unless monochorionicity is confirmed at less than 14 weeks, the fetuses they appear concordant for growth and anatomy. In general, monochorionic twins they require a single puncture, but in case of the discordant anomaly, both fetuses they should be sampled. In a structurally or size discordant monochorionic twins, discordant aneuploidy is exceedingly rare, and documentation and discussion of the heterokaryotyping monozygotic abnormalities it should take place. When anomalies are identified in the first, an increase in one of a monochorionic twin pair, which may be markers of aneuploidy, the merits and risk of the CVS versus waiting for a double amniocentesis at 15 to 16 weeks, this discussion should be done. The discussion should be carried out. Dichorionic twins, they require dual puncture in most cases. Meticulous mapping of the position of the twin, it should be performed both at the time of prenatal diagnostic test and invasive treatments. For dichorionic twins, selective feticide using intracardiac lignocaine or potassium chloride injections of the affected fetuses should be done. This is only possible in dichorionic twins and their separate intertwin circulation due to their separate intertwin circulation. Intracardiac feticide is associated with increased risk of pregnancy loss. So this is for the dichorionic twins. Now for the monochorionic twins, selective feticide by intravascular injection of an abortifacient is not an option due to the presence of placental anastomosis. We should offer vaso-occlusive techniques like laser ablation, radiofrequency ablation, or bipolar diathermy of the cord. The potential risks of intrafetal umbilical cord ablation they should be discussed prospectively, like co-twin loss and the neurological morbidity. It should be discussed with the woman. What is the outcome? Co-twin survival is seen in 82%. Fetal loss is seen in like 15 to 18%. PPROM occurs in 10 to 15%, and neurological morbidity it occurs in 15%. Monitoring for the DIC is not indicated in monochorionic twins undergoing selective reduction. If selective feticide is not performed in first trimester, then delay it until the third trimester till viability of the normal twin is more certain. This must be balanced against the risk of spontaneous preterm labor, especially in cases complicated by polyhydramnios such as anencephaly. Regarding vanishing twin and the fetus Paveracious, It occurs in up to 21% of the twins, and they are complicated by either miscarriage or loss of one twin in the early stage. The vanishing twin is detected by high resolution ultrasound, and it may result in fetus preparations where the anatomically preserved demised fetus it can be identified at delivery of the surviving twin. The miscarriage rate in these pregnancies is 5 times higher than that of the normal twin, and no increasing monitoring should be necessary if the baby appears structurally normal, as a pregnancy is most likely to progress as expected for a singleton, and care should be taken where pregnancies they have begun as multiple gestation in women undergoing screening for the Down syndrome. As a non-viable fetuses, they may cause false positive results. Then we should remember that if preterm birth occurs, or then the fetus is again at risk of many other complications, and if like one baby dies, it predisposes the second baby also for preterm birth, and this is associated with like more than 3 times greater risk of fetal demise for the second baby as well. Twin pregnancy is very important, and I hope that I was clear about some of the concepts. So I would suggest pay attention to this one because it is an extremely important topic for your exam.